Start.
So good evening, everyone. Welcome to 13th TUGSS India Academic. Happy to share that we have successfully completed 1 year journey of this monthly academic event. Surgeons from different countries are also participating in an international event. Today, we are discussing the most popular bariatric surgery, that is laparoscopic sleeve gastrectomy. For that, we have three eminent speakers and three eminent panelists. Let me introduce panelists first. Our first panelist is Dr. Prabhu Nasalgekar. He is a senior consultant at SCG Cancer Hospital, Bangalore. His main interest is in GI, peritoneal cancer, bariatric and laparoscopic surgery. Our second panelist is Dr. Digvijay Singh Bedi. He is laparoscopic and bariatric surgeon at Bhopal Multi-Specialty Hospital, Ahmedabad. Our third panelist is Dr. Aparna Govil Bhaskar. She is bariatric and laparoscopic surgeon at SEFI Apollo Spectra Kure and Nama Hospital, Mumbai. So now to start our session, our first talk is on tips and tricks for a good sleeve gastrectomy. To deliver this talk, we have a renowned speaker, Padma Shri awardee speaker, surgeon, and a very thorough gentleman also. He is none other than Dr. Pradeep Chaubey. His CV is like a chapter of a book, but in brief, he is chairman of MEX Institute of Laparoscopic, Endoscopic and Bariatric Surgery. He is honorary laparoscopic surgeon to President of India. He is honorary laparoscopic surgeon to Armed Force Medical Services. He is surgeon to His Holiness Dalai Lama. He is president of IFSO, that is International Federation for Surgery on Metabolic and Bariatric Disorders. He was president of Asia Pacific chapter of IFSO in 2011 to 2013. He was president of Asia Pacific Metabolic and Bariatric Surgery Society during 2010 to 2012. He was president of Obesity and Metabolic Surgery Society of India, OC, in 2006 to 2009. He is founder president of Asia Pacific Hernia Society, APHS. It is my proud privilege to invite Dr. Chaubey to deliver his talk on tips and tricks for good sleeve gastrectomy. Over to Dr. Chaubey.
Good evening, everybody. Thank you for this opportunity and honor for me to be with all of you across the country and across the globe. And I must compliment you for completing 1 year of TUGSS, which has generated so much of curiosity and so much of liking amongst the academic events, international academic events, I must say. And I think, most of the people are looking forward to this event because of its academic contents and possibly the interaction with the faculties, and also talking about the procedures and situations and conditions which are rather common, So I think it's a very interesting subject. Today we are talking about the sleeve gastrectomy, as we know that it has become a very popular procedure across the globe. And it started as a first stage procedure for BPD, but I think over a period of time, we realized that 60% of the patients are not coming back. And this is what the US interpretation was, that 60% of the patients were not coming back for the biliopancreatic bypass, and they were happy with the sleeve gastrectomy. And that's how it became the primary procedure, of course, of choice for many institutions, many surgeons, and many countries. And also, at a step down for the super obese patients for the next bariatric surgical definitive procedures. Maybe it's a gastric bypass, or maybe SADI or BPD, or whatever is the choice. So I will just share my presentation. I hope you will be able to see. I'm sure you are able to see the first slide. So my greetings from New Delhi, Max Institute of Metabolic and Laparoscopic Surgery. And as we know that today we are talking about the sleeve gastrectomy. And here I would just like to put on picture, I think, what we are talking about. So we are talking about removing the fundus of the stomach, and almost about 80% of the body and a part of antrum, if at all. And also, I think this is important to consider that the track for the food, the pathway for the food is not changed. So it is not going anywhere. And also, sometimes we try to call it as a restrictive procedure, but over a period of times, we have seen that it does not remain only restrictive, but it becomes a metabolic procedure as well because of the resolution of metabolic condition. And also, I think there is an early transit of the food to the ileocecal junction, which has gained importance in the last 2 decades as one of the important factors for weight loss and metabolic resolution, especially for the metabolic resolution. So I think I'm sure because we have a little more time today, so we can talk about the indication. And as I just mentioned, that the indication of sleep started, in fact, as a super obese patients who had a very high anesthesia and surgical risk because of the super obesity. And there was, if BPD was done in those patients, had a high mortality and morbidity. So it was decided, but that sleeve today, if you really consider today's sleeve, that sleeve used to be quite big and quite voluminous to start with. And the idea was to restrict definitely, but for a short-term restriction. But I think conceptually today, when we talk about a sleeve, we talk about a long-term sleeve, and hence it has to be small. And also we have to consider the possibility of the dilatation of the sleeve. And that's why over a period of time, it has become smaller and smaller. And also, as I said, at the moment is gaining popularity as a primary procedure. Now, I think we are present indications are the young patients, some patients who have got inflammatory bowel diseases, some patients who have got a gastric lesion where you would not like to exclude the stomach for the future endoscopic procedures, especially in countries like Japan, Korea, where the carcinoma of the stomach is reasonably common, and they would like to do the periodic endoscopies to see the condition of the stomach. So I think in those countries, it's become especially more indicated. Contraindications, I would say that, a severe gastroesophageal reflux disease, a hiatus hernia, Barrett's esophagus, I would consider them as a contraindication because the situation may become worse in spite of the fact that the patient may lose weight. Of course, the relative contraindications, which depends on the judgment of the treating team, is of course the shorter surgeries where you expect the patient to not be subjected to longer surgeries, maybe poor myocardial reserves. And also, I think today it's more and more in cases where there is a liver issues related because of NASH, so cirrhosis, portal hypertension, and of course, as we discussed, any conditions which are not very conducive for a longer anesthesia. And sometimes it's by choice that the patients ask for a sleep, so we have to respect that. In our institute at Max in New Delhi, we follow the VLCD program for 2 weeks in super obese patients. And over last 2 decades, we have realized that it really not only helps in the surgical condition of sort of, making the job of a surgeon slightly less problematic, especially when you go to the fundus, when you go high up, if the left lobe of the liver is bothering in the super obese patients, and it creates a lot of sort of difficulties. And sometimes it may amount to even leading the fundus behind, which is absolutely not desirable. So I think it's good to wait for 2 weeks in these patients with VLCD, and generally they lose about 5 to 7 kilograms of weight, and most of the weight is lost from the liver. And I think also we have seen that a lot of their metabolic issues start settling down. And that really gives a good opportunity to our anesthetists for the management of such super obese patients. Well, I think special instrumentation, I would not really say much, but I think all these are the bougie and endostaplers, needle holders. Apart from this, I think it's true for practically all bariatric procedures. We would like to definitely mention here the bougie size about 36, which is our choice of the bougies. We know that in the past, I think, few surgeons have gone up to 34, 32, even 30 size bougie. But we very strongly believe that making it too tight a sleeve will increase the chances of the leaks postoperatively and also the reflux. So I think looking at the literature and other things, we feel that a sort of well-fitting 36 French bougie is good enough. And it should not be tight, so that when you are putting the, clamping the stapler, it should not be pulled, should not be stretched. The bougie, you should be able to move easily without any obstruction. Now, this is the typical layout. I'm sure a lot of surgeons are standing by the side of the patient, but I think when we are starting any surgery, which is hiatal surgery, I would say, and why I'm giving importance to the hiatus in this is that very important to dissect the fundus and reach to the hiatus, either for repair or for removing completely the fundus. So this is a very good position, where it's ideal position, as we have always mentioned, that the hiatus is best approached laparoscopically and the most ideal. So the surgeon is standing, and the target area of operation is also straight, and then there is a monitor. So everything is lying in one line. Then you have a left hand and the right hand, which is available to you. And the assistant is on the left of the patient. And of course, the camera person is on the right of the patient. And you can look at the monitor, which is in front. And for the camera person, you can have the slave monitor on the opposite side, it between that angle made by the head and the left limb. So this is exactly what we would like, especially for the younger surgeons who are starting, because you will be ergonomically well placed. Now, point here I would like to say is that we generally would like to have 4 ports or 3 ports. It all depends. I would like to insist that please do not count the size and the numbers of the port, because the most important thing is the safety and ease with which you can operate. And we know that the scope, generally we prefer a 45 centimeter longer scope with a 45 degree lens. So, and you need surgeon's left hand, right hand, and we would like to add one port in the left mid-clavicular line, and that is for the assistance. We love to use the classical Nathasson's liver retractor. Again, I would say that the most important dissection is at the hiatus, and in these obese patients, Nathasson provides a very good alternative, in spite of the fact that it adds another port closer to the xiphoid on the left side. So this is this thing, but when you talk about the patient, this is how the patient looks. And here I would like your attention towards you to see this port, which is high up on the left side, because we know that the midline will have the falciform ligament. Most of the surgery is on the left side. So we prefer, and you see that it is not related with umbilicus, but it is more corresponds to the xiphoid, because in obese patients, xiphoid is the only constant anatomical landmark. And the umbilicus, depending on the BMI, depending on the longevity of the obesity, it will all vary. So I think we should just concentrate, because Again, I would emphasize that the main dissection, main problem, main issues, technical difficulties are at high stress. And this is the best approach to be close to the hiatus, about 18 to 20 centimeter, so that we can have a good look at that and good control of the hiatus. Now, this diagram, I would like to say that at the almost like a 60% body, or maybe half of the body, our dissection starts there. And first step is to divide the greater omentum close to the stomach and move in upward direction. As you see in this video, we are pulling up the stomach using the ultrasonic device, and we are going up into the close to the hiatus here. Now, what you are dividing is the short gastric vessel. But if you really look practically, you will find that every time, every surgeon will not be using the ultrasonic device just for the first use. What I mean is that most of us, we are reusing these ultrasonic devices and the probe, the instrument. So what happens as you keep on doing more and more, you find that ultrasonic device may or may not be as reliable as it is quoted or it is given to understand. Because the more use you do, the sealing mechanism is not as effective for 6 to 7 millimeter short gastric vessels. So what we have, generally we always insist and teach that when you come to the short gastric high up in the first, it is better to apply a clip on both the sides, or at least on the splenic side, and then divide it with ultracision. We have time and again, we have seen some patients coming with this history of bleeding, and the patient needing a lot of transfusion, because in obese patients, it's very difficult to reach in this area and control the bleeding, and that too from the short gastric. So maybe I would say that it is better, and it's not time consuming. Maybe if you are using the probe for the first time, maybe you can avoid it, but just avoiding this step makes no difference. And we insist that it is to be clipped. And then, of course, we go proximally, and our aim is to dissect the fundus completely so as to expose the left crura. Now you see that we are going away, and then we are trying to reach to the left crust, because that will indicate that we have completely separated the fundus there. And this is the dissection, which is on the upper side. And then once you have done that dissection, we move towards the pylorus, up to the crow's as a feet, and here also, sometimes in these patients with portal hypertension and NASH, you may find dilated vessels. And I would say, whenever you have a dilated vessels, it is better to clip them and then divide them, rather than sort of, using the precision and causing. We are going to the left side, pylorus. So you can make out, but as I said, whenever you find a bigger vessels, dilated vessels, there's no harm in just putting a clip, which will save the bleeding and also more surety and security to the patients. Now you are just watching here. We generally, you can see the crow's feet here, and that is our area of dissection here on that side. And then next is now the insertion of calibrated tube here, 36. And here we want to see, because this will prevent narrowing at the first stapler side. Once you have mobilized, we always like to put in a bougie, and you can see in this thing that the dissected stomach and the bougie is coming in, which is directed towards the pylorus, and so that it remains in the lesser curve. The bougie gets turned and it remains in the lesser curve. I would also like you to observe that we always hold the stomach at the greater curvature. Whenever you are holding the stomach, don't hold the stomach wall anterior or posterior. Now, once you are holding there is an equal traction on anterior wall and the posterior wall of the stomach, and that will prevent few of the complications of the sleeve, which we have observed. So now the first, after the first fire, we continue all along the sleeve, all along the bougie, not causing any traction on anterior or posterior wall. Here, I would like you to see that the stomach should be held from the greater curvature, both sides, so that there's equal degree of leg strength of anterior wall as well as the posterior wall. So now we see that the bougie is there. Now we are trying to lift the stomach, as you see, from the greater curvature. And this gives the equal distance from the lesser curvature. And this is the first fire. You can see the loosely it is quite away from the sleeve. Otherwise, over a period of time, this may be the area of stenosis and may need a reoperative surgery. And then we go along, but you will see that the stomach wall is not stretched, it's loosely held. And now we have got all the staplers which can have a controlled direction. So there is an equal distance between the short on the lesser curve and the greater curve, and this way we continue moving here on the top. Now I think we reach to the left side, and this is, I think, probably most important thing in my presentation today, which possibly will give our colleagues a very safe sleeve. Now you see the dot. First of all, I think we look at the dot. The dot is actually at the upper pole of the spleen, which is not variable in most of the patients. Then you see the length, the direction of the stapler. We always try to point the stapler towards the upper pole of the spleen. This, by and large, takes the fundus completely. At the same time, it doesn't pinch on the esophagus. If your stapler direction is medial than this, then there are chances that we may pinch the esophagus, and that is the site of leak. Another point, I think, as a surgeon, I am many times we sort of debate on this. Now you see that this stapler, there is enough length of the stapler which is crossing the stomach wall. Sometimes what happens that you reach up to that and you see, oh, I think, instead of taking another stapler, why should I waste another stapler? And this is where you go wrong, because then the leak takes place. So here, I would just like to again emphasize that point your stapler last fire towards the tip of the spleen, and do not bother about extra stapler, because there should be spare length of the stapler which should be available. I'm sure you will be able to avoid a lot of this thing. And when we started almost 2 decades back, we were using the synthetic bioabsorbable staple reinforcement, especially for the last staple, because the stomach becomes thinner at that time. But now we have, I think, almost about 10 years, we have given up this thing, because the stapling technology has improved a lot. And the staple formation has improved a lot. And that is the reason why you do not now need any reinforcement. And we are very convinced, and also we are quite happy with our decision of not using it at present. And I've just shown it for somebody may have this point in one mind, And I wanted to clarify on that. Yeah, okay. Okay, now comes the question of the lateral traction, as we have discussed this. Now for bleeding, we are very sure that we use the Liga clip 200 at the spurter side or any side which you feel is bleeding. And I'm sure you all must have seen the glue and the powders, etc. sprayed. We generally do not believe much on that. And applying 200 clip at the spurter, whenever you see, or if there is even if you see a little bit blood, because all these patients are low molecular heparin, may have the bleeding tendency, we don't want to go back in. Applying one extra 200 clip rather than one less clip. And this, it gives a very reliable hemostasis. Now you can see that the bougie is withdrawn and it's a loose sleeve. We occlude at this with the intestinal forceps and distend the bougie, the sleeve with methylene blue, and very carefully look for any place shows blue color. And with, again, I would say, emphasize that with the increasing technology and the modern staplers, we have hardly find any leaks during this period. And we strongly believe that the leaks which are taking place at the upper part of the sleeve are ischemic leak, or maybe the stapler which has gone too medial over the esophagus. So this is another point which we would like to emphasize. We put the specimen into the bag, and we put a suture on the one pole of the sleeve specimen, and that suture helps us in pulling the stomach out in a longer fashion. Now you see that this is the endo bag. You will see that because it prevents the infection of the wound as well. And you will see that the silk, which is always outside, And this way we remove the specimen through the 15 millimeter port. And we prefer to use a 15 millimeter port for extraction of the specimen rather than using a 10 or 12 and then dilating it, because dilatation of this causes a lot of pain to the patients. And of course, we are going to close this port. All the ports are closed. We are fond of this particular silicone drain, which we put in all the cases. And also you can see that we close all the 10 mm ports in these patients, because all these obese patients are more prone for the herniation of the port. And now I think post-operative management, of course, like any other bariatric, this thing, we give the clear liquids discharge when the oral intake is 1.5 to 2 liter in a day, which may happen in the second day, or maybe in some patients in a third day. Generally, we keep them for 7 to 10 days on a liquid diet, and then gradually start increasing and the diet accordingly. And by and large, in 4 to 6 weeks, they are almost in the normal this thing. Well, complications, we all know that staple line disruption is possible, bleeding from the staple line, intralumen or extralumen, both are possible, as I said. But not what we have seen is that now this has reduced very significantly. But the third point I would like to emphasize, the short gastric vessels bleed sometimes. And I would re-emphasize that putting in a clip on the short gastric, especially at the upper pole of the spleen, which has got the very big short gastric vein and vessel that can prevent this particular leak. Injury to the spleen, if there is this thing, then we have to use a flow seal. We don't like to remove the spleen, and we have been happy in one odd case where the spleen gets injured for some or the reason. So I would like to summarize here. We use about 36 to 38 size Fuji, and we like to use a staple, of course. Buttress, we are not preferring at this time. First firing, we do not like to include the pylorus. We like to keep the pylorus as it is. Mobilization is important up to the fundus, and at the moment, reinforcement is not there. So that ends my presentation, and with my greetings, our institute and our colleagues who have made possible to have the very study and protocol-based Center of Excellence and the bariatric program. Thank you very much.
Thank you, sir, for sparing time and enlightening us by giving wonderful tips and tricks to do laparoscopic sleeve gastrectomy, like putting up clips at splenic site near short gastric vessels, keeping the stapler towards the upper pole of the spleen, lifting the stomach at greater curvature, and putting the clip for the hemorrhage side instead of reinforcement. So these are wonderful tricks and tips. Thank you, sir, once again, and wish you happy Diwali. I think you have to go for dinner meat.
Yeah.
Thank you, sir.
So thank you, Diwali. Happy Diwali to all of you and for this opportunity. And have a good night and good academic event. And I look forward to the next presentation of TUGSS, if at all, whenever is there. It will be a pleasure to be. Thank you.
Thank you, sir. Thank you, sir. Over to Dr. Prabhu for next talk.
Thank you, Dr. Smitha. So obviously you heard from it's almost like the Lord of the Rings trilogy today. So we heard from the chapter 1. So obviously it makes sense to have the next best speaker on the forum is Dr. Mahendra Navaria. So he's going to be talking about leak management of sleeve gastrectomy, and we couldn't find a better person to talk about that. So just a brief history about Dr. Mahendra. He's obviously well known in the bariatric circle. He's been credited with more than 10,000 surgeries in his name. He also holds a few LIMCA records, including the youngest person. And going to CV, I was obviously honored to know that he's one of the first pioneer to do sleeve gastrectomy in India, including the Scarless and the notes. He's been member of a very prestigious organization. Looking at his publication list, he has got consensus articles with my colleagues in UK and in India. So without much ado, Dr. Mahendra, will be very much looking forward to your experience over these years and sharing one of the most dreaded complications all surgeons fear in sleeve gastrectomy, which is a leak. Over to you, Dr. Mahendra. You're muted, Dr. Mahendra.
I said thank you, Dr. Sumita and Dr. Prabhu, and thanks my TUGSS team, particularly Dr. Kamal Mawar, my close friend from UK, who initiated the whole program. I'm glad that I'm part of this program, and today I'm with you sharing my experience of sleeve leak. So just let me just share my screen. So it's a greetings from my hospital, that is Asian Bariatrics Plus at Ahmedabad. And this is the talk assigned to me, the management of leak. So we need to know that LSG is the restricted procedure which induces early satiety by resecting the gland producing cells of the fundus. It is the most common procedure done today because of simplicity and efficacy compared to the gastric bypass or mini gastric bypass. But its complications can be even more severe, which can be staple line leak, bleeding or strictures. And based on data published earlier of close to 12,000 plus procedures of LSG by International Sleeve Gastrectomy Expert Panel consensus meeting in so 2011, where even I was part of it, the leak rate was 1.06%, but it can vary from 1 to 3% in primary poster and up to 10% in even the revision surgeries worldwide. So the sleeve leak can be classified by different authors. The Sanders et al., he's classified it as early, which is ranging from 1 to 4 days, intermediate for 5 to 9 days, and late is more than 10 days. But Rosenthal has published, classified it differently. So acute within 7 days, early with up to 1 to 6 weeks, late is 7 to 12 weeks, and chronic leak is more than 12 weeks. The clinical presentation, there's a type 1 wherein it is localized with no systemic complications or manifestations. It can be type 2 where it is having a dissemination of peritonitis or sepsis. The site of leak can be proximal in the upper part of the stomach, middle part of the stomach, or distal part of stomach, and their radiological appearances can be different or mixed varieties. If you look at the different reported publications, if you look at all the leaks which are there worldwide, the most of them are in the proximal 1/3 of the stomach, and that is mainly close to G junction. If you look at different studies, they're ranging from 75% to 100%, and very rarely it is in distal third or other part of the sleeve. If you look at the causes of leak, it can be mechanical, usually which appears within 2 days of surgery, that is early leak. Ischemic leaks can usually appear from 5 to 6 postoperative days. That is usually we see in any surgical complication. So that is why we try to observe this patient for first 1 week to 10 days to diagnose the leak in this patient. In a multi-center experience of close to 2,800 patients, after sleeve gastrectomy, it was concluded that improper vascularization due to aggressive dissection of the posterior attachments of the stomach in upper part of the sleeve. There can be thermal injuries, and staple line devices missing is another cause, and distal stenosis, which is leading to proximal stasis or pressure leading to proximal leaks. So these are the causes of leak. So if you look at this diagram, it can be mechanism can be mechanical, which leads to because of high gastric pressure, strength of the staple line, the pressure is higher than the strength of the staple line, or it can be ischemia due to devascularization of the G junction. So we need to understand that sleeve is having is related to high interluminal pressure system, which is created after sleeve gastrectomy, and the most common factor which is responsible for mechanical, tisular, or ischemic related leak because of high pressure. The prevention is always there when we are trying to handle the tissues using our electrosurgical devices like ultrasonic devices or staplers. We can avoid distal stenosis by avoiding the corkscrew type of sleeve, which we can do, or we should have a staple line which is just on the lateral side of the stomach. And by using a proper technique of staples, like as Dr. Chobe just said, that we should use only green at the antrum and should not use blue at the antrum, because the thickness at antrum is different. So we need to select a proper staple, particularly more so in the primary surgery, and the different type of staple heights we need to select in the revision surgeries. And there is another one study which they have tried to place a nasogastric tube for 24 hours to reduce the interluminal pressure, but very few studies favoring this. I particularly never uses this, but the size of buoy is very, very important. Whenever the size of buoy is less than 36, the chances of leak are very high. In fact, I had only 4 leaks when I was using only endoscope as a buoy and not the intragastric buoy which is being used. So there was a large systemic review, almost close to 4,800%, 4,900%, and with a meta-analysis of more than 9,900, close to 10,000%, suggests that larger the buoy size, lesser the chances of leak rate. If we talk about queries in this leak, with the leak test, which is the best leak test one can have. We use methylene blue during leak test, which is having high sensitivity and specificity. But many people, they use endoscope and air leak test to check the leak. I was using endoscope earlier, but nowadays I don't use anything. But that is mainly because I never had leak after I stopped using endoscope. The use of closed suction drain at the sleeve site is not very good thing to detect the leak, and may not even helpful in reducing the drainage of the collection, which is caused because of the leak, because of thickness of the fluid which is there because of the leak. So there is a question arises whether staple line reinforcement by suturing or buttressing prevents the leak in this person. And there are large randomized prospective trials and recent meta-analysis has shown that there is no difference, no significant difference of staple line reinforcement. And most agree that reinforcement is usually helpful in reducing the bleeding chances, not the leak chances. There is a another study which is published, which is showing that in fact staple line reinforcement can increase the chances of leak after the sleeve gastrectomy. I never uses staple line reinforcement. Now comes the diagnosis. The early detection is the most important part, which is having a better outcome, and one should be having a very high suspicion in these patients. So any patient who is not behaving normal after the surgery, whether he is having pain, discomfort, nausea, vomiting, we should be more cautious. And there is a debate which is existing that which modality of diagnostic tests having high sensitivity or specificity in these patients to diagnose the leak early. The clinical presentation may vary between asymptomatic patients diagnosed only by routine imaging studies. There can be signs and symptoms of septic shock, which includes fever, abdominal pain, peritonitis, leukocytosis, tachycardia, hypotension. And the studies published by Sens and Dawker, the fever is the most important clinical factor in the diagnosis of gastric leak post-sleeve gastrectomy. So whenever there is a fever in this person, we should be more cautious, and we try to be more aggressive to find out the cause of fever if it is present. Include the upper GI series, but many percent, or I personally feel, if we have the availability of CT scan or hospital, we should try to do a contrast enhanced CT scan to do a diagnostic workup. It is the best non-invasive modality to detect and confirmation of the gastric leak, has the highest detection rate of gastric leak up to 86% of patient. Upper GI radiography, that's the upper GI swallow study or endoscopy. If CT is not available or difficult, we can transfer the patient. And concerning the routine performance of gastrostomy swallow, is able to detect the leak size, but still people recommend it to be done routinely to detect the strictures or even twisting of the sleeve, or which can be just to have an anatomical assessment of the sleeve which we have created. CT can always show the air in the subdiaphragmatic area, or we can have the contrast leaking around the subdiaphragmatic area around the spleen. This is a gastrography study which is showing a leak here. And similarly, if you look at the algorithm, any person who comes to us with abdominal pain, we need to find out whether person is having fever or tachycardia. If there is fever tachycardia present, we should do CT, abdominal CT with the water-soluble contrast study as well as IV contrast. And if it is positive, try to do management according to condition of the patient. And if there is no fever or tachycardia, do a complete blood counts and CRP. If CRP and blood counts are in high index of infection, try to do abdominal CT, and then we should follow this. And if CBC, the blood count and CRP is normal, we can conserve this person, observe them routinely. But at the same time, I think we should look at the patient's progress also. If they are not behaving properly the way all other patients are behaving, try to keep them under strict observation and try to do more investigation in these patients. Many times we do upper GI endoscopy or gastroscopy. If we find any lesion or perforation, we can treat them. And if you look at the clinical condition of the patient, if the systemic evidence of illness, try to do diagnostic or therapeutic laparoscopy and try to tackle the problem. If there is no evidence of systemic illness in the terms of sepsis, hypertension, or anything, we can observe them medically and treat them without a non-surgical management. Now, the management depends on many factors, which can be general condition of the patient, whether the patient is stable or unstable, time of presentation, whether it's early or late, severity of the leak, expertise available in the hospital around you, or interruptive findings which are present during the diagnosis of the laparoscopy. So this is another algorithm, almost same thing here, but if there's an early leak, which can we can do laparoscopy, lavage, put a drainage at the collection, try to suture the defect and drain the defect and put an NJ tube, and you can then put an endoluminal stent to treat these leaks. Endoscopy technique can be endoscopic closure technique, which can be endo clips. With the newer clips which are available are promising. There are sealant materials like fibrin glue and cyanoacrylic glues which are available, but the most common use are endoprosthesis like stents. So if you look at the modalities of the management, the non-surgical management is having success rate of close to 40 to 70%. Still, we have close to 30 to 60% patients who may not have healing of the leak. These non-surgical management can be stent placement and drainage. We can have laparoscopic lavage and drain placement and put an NJ tube. We can have endoscopic glue injection and fibrin sealant at the leak site, or we can put a T tube at the site of leak. The stent placement, the idea behind this stent is to create a temporary bypass of leak site until healing occurs spontaneously, and it is getting popularity after managing post-sleeve leakage. For the management of proximal leaks or middle part of the stomach leaks, not for the distal part of stomach leak, and 6 to 8 weeks are the optimal time required to put these stents to have a good healing. And Nguyen et al. Has used self-expanding stent with success rate of close to 100%, but in other studies, the success rate is close to 78%. Now we need to understand the pros and cons of these stents. The advantage is that we reduce the intragastric pressure, we bypass the leak area, and we can resume to nutrition as early as possible. And in the problem area, if you look at, there can be migration, there is hyperplastic reaction, which lead to obstruction at the proximal part of the stent. And there can be stenosis. When we keep the stent longer, we can have stenosis at the site, or even we can have stenosis even proximal to these stents because of hyperplastic reaction which occurred. So migration, to avoid migration, one can have such a kind of thread which is placed to hook up the suture. The problem here is that it is a cumbersome to hold this stents there. This is endoscopic placement of the stent. This is a contrast which is injected proximal to the placement of the stent. So you can see this in fluoroscopy, and then you can put a guide wire and you can put a stent over it. So this is a mega stent which is placed, which is covering from G junction to the till the duodenum, and this is how it looks by endoscopy. This is how it is sized. So similarly, like mega stent, we have a beta stent, which is the problem with the mega stent is that it is keeping both the G junction and pylorus is open, so you can have bile reflux which is coming up, and patient is having a lot of reflux in esophagus. They may not tolerate such kind of stents. But recently we had seen a beta stent which is having a dumbbell shape of stent, which can be just applied at the G junction, and it will cover only up to the leak site of the upper esophagus, upper G junction, and you have the rest of stomach which is normal, and you don't have risk of bile reflux. So the tolerability of these beta stents are higher than the mega stents which we have used. So these stents are not without any side effects. In a study which is published in 8 patients with sleeve leak managed by the stage placement, the stenting was failed and premature removed in 4 patients when complication like migration, kinking, hematemesis, or obstruction occurred. The migration index is as high as close to 30% in these patients. So these are different type of stents. So a complete endoscopic approach is suggested when we can do endoscopic approach by for such kind of leak, which we can do complete washout and drainage of the natural or through the natural orifice. Like we can go to the leak site, wash out all the collection with the help of endoscope, and we try to drain it. We can divert by using a stent, or we can even apply the glue or clips to close these defects. Many people has used even other devices like our interceptor defect closure devices, which is placed to close such leaks. If you look at the surgical options, the primary closure which is technically challenging because the local active inflammatory component is very high, and it's very difficult even to identify the structures there at the site of the leak, which is difficult. Even eventually we can have failure of the suturing at that site. Though this is a video of a leak after sleeve gastrectomy, wherein we have placed a T-tube at the site of the leak. So this is a sleeve. This video is more than 15-year-old when we had this leak. This is, I think, my second leak in my life. Nobody else was doing sleeve those days, so I never knew what to do. So this is what came in my mind. So thinking that why not to reduce the pressure of this stomach by putting this tube, and eventually once the track is formed around this tube, we can remove it. So this is all secured around it so that you don't have peri-tubal leak. If you can, and this is a drain which is placed just behind this stomach, the leak area. Similarly, there is a concept of salvageable gastric bypass, which is the most essential factor when the failure of conservative management of sleeve has failed, and it is used to relatively reduce the intraluminal pressure of the stomach, and by converting into Roux-en-Y gastric bypass. So similarly, Balthasar has used first time, that is what he has published, that he has used a Roux-limb to cover the site of the leak, and then there was anastomosis, the stomach which was conserved, and this Roux-limb has helped curing this leak. So we need to understand that reoperative surgery in bariatrics is very complex and demanding area, which require considerable primary bariatric surgical experience. This is another video wherein we are doing converting a sleeve leak into gastric bypass. So this is a leak. After the sleeve, you can see the methylene blue, which is seen. You should look at the sleeve, which is edematous and thick. I just divided using a green cartridge, but if given a choice, I would prefer. So this leak was close, I think, in year 2006, again, almost 16 years back. I converted this sleeve into gastric bypass, which is technically very difficult because those days these mega stents were not available in our country and there was no experience of any gastroenterologist putting a stent in these leaks. So I just did it because there was nobody to guide me what to do in such leaks, and this is what came in my mind, and I converted into gastric bypass, thinking that if you can reduce the intraluminal pressure of the sleeve, I think it will heal. So I did, this is the Roux-en-Y gastric bypass, this is jejunum, which is being done. Then root limb is taken up, which is covering up to the G junction. So you can see the loop is reaching up to the G junction. And I always take a seromuscular layer and so this is a seromuscular layer which is taken till the full length of the staple line of the pouch which we have created, the new pouch which we have created. Now, if you look at the leak area, I just extended it a little more. So now this becomes the stoma, and I'm taking the vical suture here, which is an absorbable suture, full thickness through and through, to do a complete anastomosis here. We need to use non-absorbable sutures even if there is a presence of infection, because if you use absorbable sutures here, if you use non-absorbable sutures, that can lead to future ulcer formation and other problems. So I try to avoid non-absorbable suture whenever we are doing a full thickness suturing and on the stomach. This is anterior layer, full thickness. And then we can do one more layer of seromuscular just to complete this. So there are different studies which were published, out of which the stent management was compared with the gastric bypass surgery, and out of this 38%, of which 15 out of 38% needed premature stent removal in the stent group because of the complications arise because of stents. The stent removal time after management of these leaks completion was 4 to 6 weeks, with 76% successful rate of leak in this patient. On the other hand, if you look at the gastric bypass patient, of 21% who underwent gastric bypass, only 1% had incidence of unrelated complaint like pneumonia. The median stay of hospital stay was 11 days, and success rate was 100% in these patients. These are few other publications and the management of sleeve leak by Roux-en-Y gastric bypass. This is from our own center from Dr. Palnivelu, Pravindra's publication. So early or late surgical intervention, we need to do early salvage gastric bypass post leak resulted into reduction of total medical cost as well as the length of hospital stay. And in another study of among 6% who presented with leak, 4% had the revision surgery in late phase, while 2% received early intervention. Late intervention versus early intervention had associated with increased risk of medical expenses of more than 500% versus 200% in early intervention, and prolonged hospital stay of 131% in late intervention versus 38% in the early group. This is my first leak actually, which was presented to me a little late. And you look at the abdomen, this is in year 2005. The surgery was done at the center, which was not equipped to do the revision or managed the company, the first surgery of that center, and that patient had leak, who was then shifted to my center, and we had to manage. And when I was doing this, I was not even able to understand and discuss with anybody in the country what to do in such complication. And I personally decided myself that I will convert this patient to gastric bypass. So look at the edematous tissue all around the stomach, peritonitis which is present, but luckily this person was stable hemodynamically, so I decided to complete this surgery laparoscopically and to convert into a gastric bypass. So I think this was the first leak of India of sleeve gastrectomy, which was managed those days. And if you look at this is infracolic compartment. You have a lot of pus flakes present in the infracolic compartment, the interbowel loops as well, which was then cleaned. I'm sorry for the poor quality of videos, because those days the quality of our endovision system was not that great, and this is a very, very old video. But just to show the concept, I'm showing this video so that you can understand that these kind of even surgeries can be done in the presence of peritonitis and fluid around the bowel loops. So this is creating a rule limb here, dividing the jejunum about 50 centimeter distal to DJ flexor, then dividing mesentery further down so that you can take this rule limb easily up to the G junction. Then I placed a marker. Then this can be just sutured at the end, distal end and proximal end, so that this outer drain can be used to manipulate the bowel loop. This is enterotomy, which is created to do the jejunostomy. And then closure of the enterotomy by using the stapler. Then the mesentery defect is closed. So this is all possible because I was doing Roux-en-Y gastric bypass those days, so I could handle this sleeve leak by Roux-en-Y gastric bypass. But for somebody who is new in the field, who don't know how to do Roux-en-Y gastric bypass, may not be able to handle such situation. So high volume centers with good experience is very, very important to handle such complications of leak, if at all you encounter. So this is now I'm just tracing the biliopancreatic limb, and after doing the JJ, I will go back to the pouch, the stomach, to create a new pouch of the stomach by dividing the sleeve by stapler. Here again, I'm using the now I'm taking the seromuscular suture till G junction so that jejunum will go up. And we will have complete coverage of serosa at the site of the leak. This is suturing device which I'm normally using. This is enterotomy done on the stomach side, just opposite the site of the leak. And then I will do a full thickness suturing here using these sutures. So this is the anastomosis. Then gastroscope is passed through the leak site, which was then passed to the jejunum. So you can see the endoscope, which is passing through the leak site to the rulim. So this is two-layer anastomosis, which is done using endocyst device. And after this, I even did the feeding jejunostomy. This is the fourth layer. This is drain which is placed, and this is the catheter which is placed into jejunum for feeding jejunostomy, which was then. But to my surprise, I was thinking that I may use this feeding jejunostomy because the anastomosis might leak again. But to my surprise, even this kind of a bad tissue even has healed so well, and there was no need to do or use a feeding jejunostomy for long. So we could use the oral diet in these patients after 2 weeks, and the recovery of this patient was very, very smooth. I had another patient wherein we had a stricture of the sleeve. Oh, sorry, that is not part of my presentation, so I think we can avoid this. And with this, I thank you, all of you who are here to listen my talk, and we can take the questions if we have any. Thank you once again.
Thank you very much, Dr. Mahendra. That was a wonderful talk about all the presentation, about the leak management. So if you don't mind, I think we'll discuss the questions at the end. So we've got one more talk, and then we'll have a panel discussion about the thing. So I'd like to invite Dr. Digvijay Bedi, my co-host, to kindly introduce the next speaker, and we take it on from there. Over to you, Digvijay.
Yeah. So good evening, everyone. It's an honor to introduce the man himself, Dr. Mohit Bhandari. He's a director of bariatric surgery at Mohit Bariatrics, and he's chancellor of Sri Aurobindo Institute of Medical Sciences. His accomplishment list is a long thing, so let's just directly listen to him. He's going to talk about introduction to new technology in sleeve gastrectomy. Over to you, Mohit.
Good afternoon, everybody. I am Dr. Mohit Bhandari. I'm a bariatric and a metabolic surgeon from Indore. At the outset, I would like to thank TUGSS India for inviting me for this particular presentation. It's an introduction to new technology in sleeve gastrectomy. Bring greetings from Indore. Any of the member of TUGSS Society would want to visit us at Indore to learn bariatric metabolic surgery, they are more than welcome. These are my disclosures. I work with Professor Galvao Neto. He is the Director of Bariatric Endoscopy Services at my center. These are the case mix which we have done, and as you can see that sleeve gastrectomy has seen several variations. And when I was allotted this topic of talking about the different technological variations of sleeve gastrectomy, I thought they wanted me to talk about the endoscopic sleeve. But then I thought that if I read the topic, it suggests that I should talk about what has happened to sleeve over 10 years, how sleeve has changed, what additional technological advancements have come to sleeve. This particular slide suggests that we have done close to 4,600 sleeves, but as you can see that you see the endoscopic sleeve in the green there, which is another, I would not say modification of sleeve, but a type of sleeve created by endoscopy. Similarly, you see a lot of robotic sleeves happening and a lot of banded sleeves happening. So let me take you through this journey of sleeves. This is our own thing. In 2010, we also started with sleeves, but we graduated to gastric bypasses very early because of Dr. Phoebe. But then what we saw that both sleeves and gastric bypasses have had a lot of weight regain. So in 2011, we were performing banded sleeves. We published this data very recently. And then we also simultaneously started banded gastric bypasses, which means we were not very satisfied with the results of our banded, very early results of our banded, with non-banded sleeves and bypasses. Then came the single incision laparoscopic approach, which was another advancement to sleeves. And then finally the robotic approach. Now we are seeing the endoscopic sleeve gastroplasty as one of the commonly performed techniques where the sleeve can be created also by endoscopy. So, you know, these are several developments which took place. Sleeve gastrectomy is now a standalone procedure, or although it was not devised to be one, it's the most commonly performed bariatric procedure in the world, and long-term data have demonstrated similar effectiveness in terms of weight loss and resolution of comorbidities when we compared them with gastric bypass, which is still the gold standard of bariatric surgery. Now, you know, the outcome and the risk matching of an operation can only be performed if we have an algorithm to treat the patient. Now, most of the youngsters who are watching the TUGS should understand that when to perform a sleeve, when to perform a bypass, and when to perform several other procedures. But when we talk about sleeves, I choose a sleeves specifically for non-diabetic patients who do not have hiatus hernia or history of gastroesophageal reflux disease, who are chronic smokers, who are chronic alcohol abusers, who have a history of peptic ulcer disease, who have abnormal liver function tests, patients with area of high incidence of gastric cancers, and high risk patients. Now I'll tell you the reason of why we do that. Why in non-diabetics? Because we already know that diabetics we reserve gastric bypass. Hiatus hernia and GERD are contraindications to sleeve. We use them in smokers, alcohol users, and peptic ulcer diseases because I think smokers and alcohol users will have a bad outcome with the gastrojejunal stomas if we offer them a bypass procedure. A sleeve has that good property that you can put in an endoscope into the first and the second part of the duodenum to check for a duodenal ulcer. At the same time, a sleeve is a surgery which is very friendly to the liver. A bypass will obviously accelerate the liver failure. So this is a very standard algorithm. I would say that more than technology, for youngsters, it is more important to know when we should be offering a sleeve. Also, most surgeons who are just beginning bariatric surgery should understand that although sleeve have become a definitive procedure, but it is, the history of sleeve is weight regain. So be prepared to have a lot of weight regain after sleeve gastrectomy. The history of sleeve is not only weight regain, but also a neoreflux or a hiatus hernia. So this one should understand that no matter how much technological advancements into sleeve would come, but that would remain the problem with the sleeves. At the same time, apart from the weight regain, the sleeve leak still remains the Achilles heel of the sleeve. So having said that, this is the first new technological advancement everybody should know. This is a single stapler, a single stapling platform. All of us know that when we do a sleeve, we require 6 to 7 reloads to fire. The first one being a black or a green, and then a gold, and then finally blue all the over, or if you use a tri-staples, then they are all the same color, the purple color. But this is a novel technology which is 23 centimeters long. It offers a very simple thing where you fire a single load of 23 centimeters to create a sleeve. This is new. I was at the IFSO Miami, and now the surgeons have started to publish even 1,000 cases with this particular stapling technology. It's still to come to India, but very soon we will have it in India, where a single stapler can be done to perform a sleeve gastrectomy instead of multiple. The robotic sleeve is another new advancement in sleeves. Although my personal opinion is that I would never use a robotic system for doing a sleeve until and unless I have a patient who has history of previous abdominal surgery or very super obese patient. That would be my choice to do robotic sleeves. The advantage being good dissection, no torque on hands, very easy dissection close to the gastroesophageal junction at the angle of his, easy mobilization of the short gastric. So that's the second new advancement sleeve is seen in last over 10 years. So you can see in this video, we are doing a robotic sleeve. This is how the sleeve is created. And you can see that the movements of the hands of the surgeon sitting on a console, seeing a 3D image is easy, and we have performed many of them. But I would, as I said, reserve it for super obese patients, previous surgeries, maybe very large hiatus. Even though the instrumentation in terms of robotics have developed, the 4K and a 3D system in combination would be the most simple but the most effective advancement we have seen in terms of technology for sleeves. Now what we are seeing that we can see a 3D and a 4K in the same system. We are seeing fluorescence imaging to detect the leaks, Firefly technology in the robotic system, the NIR ICG fluorescent technology, and several others which may be very useful in terms of enhancing the safety of the sleeve gastrectomy. These imaging systems necessarily will make job for young surgeons very easy, and they are already doing it. So this is, you can see a overlay image, the monochromatic image and the intensity map. We can detect areas of less perfusion, areas of bleeds. We can predict future leaks, complications in short. So sleeve, relatively simple operation, no disruption of GI anatomy, near regular intestinal absorption, low incidence of dumping syndrome, zero incidence of internal hernia. But at the same time, always consider that the weight loss is less than a gastric bypass. Dilation of a sleeve, it's a natural history of sleeve, neo reflux, intractable leaks, torsions, stenosis, and portomesenteric thrombosis. Let's talk about one of the latest thing which we are doing. That's the endoscopic creation of sleeves. So never we thought in the world that we will be doing a sleeve or creating a sleeve by endoscopy. And now patients who want to avoid surgery choose this less invasive reversible operation. It can be done as a staged procedure, first by endoscopy, and then you can convert it into a regular sleeve, and for super obese or high risk patients. The weight loss will not be as good as sleeve gastrectomy. It is in tune of 16% at 5 years, but it's still very good, very appreciable. That's known as an endoscopic sleeve gastroplasty. The Apollo Endosurgery is the company which creates an Apollo overstitch device. There are several others, but I just mentioned this because it's called as Opposed 2, but I'm not talking about that because it's neither available in India nor in our clinical practice. This is the Apollo overstitch device. As you can see, create a tube-like structure. This looks like a sleeve on endoscopy from inside. And a lot of young surgeons come to us trained in this modality, specifically gastroenterologists. Very good modality for a daycare procedure where patients get admitted in the morning and get discharged in the evening. Complex moves are required. It's not a very easy endoscopic procedure. It's tough even for very seasoned gastroenterologists. But yes, has a great scope. Several suture patterns have been published by Galvao, Gontran Lopez Nova, Barham Abudeb, and at the end of the day, our intention is to create a good, tight, robust sleeve which stands the test of the time. The mechanism is a little different than the conventional laparoscopic sleeve, and that is the delayed gastric emptying. So you can see that whereas in a laparoscopic sleeve, we were always talking about rapid transit, early gastric emptying, huge GLP. Talking about, we are going back. We're talking about delayed gastric emptying, feeling of fullness, early satiety. So, you know, things keep on changing in science. And the field of bariatric surgery. All I would say, please do not equate endoscopic sleeve to endoscopic sleeve gastroplasty to sleeve gastrectomy. These are two very different procedures. Creating a sleeve by endoscopy and doing a sleeve laparoscopically are two different procedures. One I already mentioned, both, one delays gastric emptying, one enhances it. So, you know, again, this is a video from my own procedure. We perform them in huge numbers. You can see this is a helix device to pull full thickness stomach mucosa. 0 suture is used with a overstitch device, and a U-shaped pattern is created. At the end, this looks something like this, a nice tube being created. So, you know, we are doing something new where we are revising our failed sleeves to endoscopic sleeves. So you see, as I said, dilation of a sleeve is a natural process. So any patient who has had a sleeve a couple of years before and now has some weight regain, you can go in with an endoscope and fix up this sleeve. The weight regain, we published that data already, is 10% total weight loss at 2 years, but that's very good because if you go on in the market survey and do the analysis of sleeves done 10 years back, almost 70% of them would have gained 15 to 20 kilos. So it makes a very good case to learn for bariatric surgeons. I'm doing a lot of training programs to introduce this new technology to surgeons so that they understand that we can revise our failed sleeves non-surgically also. It's a 30 minutes procedure. Do it, discharge patient after 3 hours. You can do it on an OPD basis also. So very, very nice procedure. Again, I would say that sleeves can be revised surgically also. One of the ways to resect the sleeve, re-sleeve, and put a band over it so that it does not dilate in future. So these are some of the ways. A lot of data from our center is coming up. I'm not going to go into the details of it. This is something where we already publish and we are publishing more. Also, just to mention, these sleeves can also be revised into banded gastric bypasses, duodenal switch, and SADI. So thank you very much. This is my team, and I invite all of you to.
Thank you, Dr. Mohit. It was a great presentation. And I think we're now open for all the questions also.
Yeah, Dr. Prabhu and Dr. Bedi will take all the questions in the chat box also, as well as other questions. Anyone is free to ask all the questions.
So unfortunately, Aparna had to leave. So I think me and Dr. Bedi and Dr. Smita will lead the discussion session. So to remind the audience, there's one question for you on the panel with now better increased and advanced endoscopy and interventional radiology. Would you still consider RYGB as methodology, or would you consider even doing MGB as a methodology?
Very good question. Actually, am I audible?
Yeah, you are.
See, I always prefer to convert any high pressure system to low pressure system to have an early recovery, number one. Roux-en-Y is still a better procedure than MGB because if you do MGB and if that leaks, you can have bile reflux, which is very difficult to manage. So one should not do MGB at all whenever you are converting a sleeve. An idea of doing Roux-en-Y is that we are converting a complete staple line from G junction to the pouch which we have created. MGB, that is not possible. You cannot cover the staple line to the full length. So one should not do MGB after this. And yes, I always prefer to do a gastric bypass, Roux-en-Y gastric bypass, in any leak at any stage. I have done chronic leaks also. I have done acute leaks also. Done leaks at 1 day, 2 days, 1 week also.
How do you decide, Dr. Navaria, to go in early or late for RYGB?
Whenever I get a leak, I decide when the diagnosis is confirmed, I'll do laparoscopy and convert it into gastric bypass. I will never wait for anything else.
So you almost
we have experience of very few patients, maybe 3 to 4 patients who underwent endoscopic stenting. And believe me, the quality of life is so miserable in these patients, having lot of bile reflux into esophagus, lot of pain, retrostomal pain, and even the stenosis proximal to stomach, which required dilatation. And removing the stent is also equally difficult. So I don't think that we should do, in my personal experience, I will never allow any person to go for endoscopic stenting unless until person is not fit for surgery.
So just
Dr.
to pitch
Mohit,
the
are you there? Sorry. Yeah. Please carry on. Please carry on, Dr.
sorry. So obviously also very great experience with sleeves. So would you consider endoscopic switching as one of the additives for managing sleeves in your armamentarium?
Is Dr. Mohit here or he left?
I think he finished and left. See, I think I'm also in a conference. He must be in a conference as well. We are in Kolkata for ISG, National Conference.
Yeah. So, Dr. Navaria, so you can answer. So the endoscopic switching device, so some guys have propagated that also as an additive for sleeve leak. Would you recommend that if you had the experience?
I think when there is this inflamed tissue, suturing by endoscopy or by any method, the way we are doing laparoscopic suturing of this leak site is not going to work. So similarly, it will not work with endoscopic suturing as well, because the tissue is edematous, friable, and they have high chances of leak. And you cannot have such a controlled suturing in endoscopy compared to sleeve, wherein we can suture it so nicely with the complete control. So I don't think endoscopy should. I think this ESG will definitely help our gastroenterologists to learn a lot of suturing, which is not there in their armamentarium at the moment, but it will definitely help them in future to do other surgeries wherein there is no infection, established or edema, and you can do maybe tumor resection and do complete suturing and other things in a healthy tissue, not the inflamed tissue.
There's a question in chat box. Nowadays, it's tri-stapler technology has come. So can we use same purple stapler for in place of using green and blue stapler? Dr. Navaria.
Yes, we can use purple suture, but personally speaking, black cartridge is even thicker than the purple, which is used in revision surgeries and inflamed tissue. So I think that is not that cannot be replaced by purple. Purple is combination of green, blue, and white. So all three at the 3 different level, we have different thicknesses. So one should not replace black cartridge with purple.
With the purple. Thank you.
So Dr. Digvijay,
Any
I
other
think you're
questions?
on the panel, so we can involve Dr. Digvijay also. So Digvijay, I know lots of young surgeons now, including when I got trained, we try to do omental suturing on top of the staple line. I've seen demonstrations where they've oversewn the whole staple line itself. So any of these you do, Digvijay?
Yeah, so I do oversew the whole staple line, and we've tried everything. We put glue, we put biodegradable materials over it. We've sutured the omentum also, but this was something. One thing is for sure. I always tell all the newer surgeons who come to my center, I say, all of these procedures can only help you in controlling the bleeding. It cannot prevent leaks. So these leaks are ischemic leaks. So, out of these things, we found that oversewing the staple line gives us a better sleep at night. So whatever suits anyone, they can adopt that procedure and go for it. Of course, it cannot be without, you can't go into a false sense of security that you've done this, so you never have a leak. So it's always better to be on a vigil. So I oversew my staple line. somebody else might not. So, but this just basically to control and bleed from the staple line, but not to control the leaks.
I think, as I said in studies which is published, reinforcement or overseeing a staple line can control the bleeding but not the leak. As Bedi also agree with me, I don't suture the staple line because we need to believe the staples which are having 3 rows, and if you use the new gun every time with a proper size of staples, I think there is high chances that we may not have any leak.
Quite right. Quite right.
So one more question on the tips. So we in UK routinely used to give Buscopan before firing the staple, so to have your muzzle wall in the stomach quite relaxed. Is that something you would advise any young surgeons? Any value in that at all?
No. I don't think that will help. Such a large stomach having Buscopan as a relaxation will not help. I think new studies which are coming up is using tranexamic acid to control bleeding and hematomas in these patients, which is coming up. I recently, when I was in IPSO, there was some publications, some presentations on this. So we can give tranexamic acid at the time of induction, and we can repeat it 8 hourly just to reduce the chances of bleed in these patients. And I think this bleeding incidence, if you can reduce, sometime we can have this chances of hematoma formation at the staple line, which is one of the cause of the leak. In fact, the first leak which I had shown was because of the hematoma at the staple line, because the place where I'd gone to do surgery, he has given IV heparin as a prophylaxis, and he's never told me. And when I was doing surgery, patient was having significant bleeding and hematoma at the staple line, and it has caused complete block and which caused leak. So
if I can just add on to this, waiting after application of the gun really helps in controlling the bleeding. Even if it is a new gun, you're taking the first gun for the case, it's a good idea to wait and then fire and not be in a hurry to quickly fire the staple. So that reduces the tissue edema and it does help in controlling the bleeding.
Dr. Bedi, how long you want to wait? Just tell the people.
Yeah. So
second, third.
The waiting time. Yeah. So I can explain the waiting time in both the standard guns that we use, that is Johnson and Covidian, is different. They have different technology in using that. But yes, when we are using a Johnson gun, we wait for 30 seconds before we start to fire, and then we do not wait between the 2 firings because the Johnson works on a different technology. For the Covidian, we wait 15 seconds between each firing as well. Once we started using the Signia gun, this actually is not very possible with the Signia gun, but with the newer technology, again, the bleeding part also is not that much. But yes, to start with the firing, even with the Signia gun, we wait for 15 seconds before we start to fire.
So one more question was, I usually put sutures of the momentum to the gastric sleeve to prevent transhiatal migration. Again, obviously you're training. So any tips of preventing transhiatal migration? Because there are lots of case reports now coming, or case series about sleeve migrating into the chest, and that is causing lots of GERD issues. So
I think the most important part is to try to avoid dissection at the hiatus, which people do while they are doing sleeve gastrectomy. They try to dissect the hiatus, try to find out this hiatus, and they try to take sutures. That is one. So one should not dissect the hiatus, and similarly, don't dissect so much at the left crest also, and try to remain 0.5 centimeter away from the G junction and let it remain as it is. And I don't think it will migrate just like that.
So, as Dr. Mahendra Narwaya said, this is quite right, that there should not be excessive dissection. But at the same time, let me tell that sleeve is such a high pressure tube. Just putting 2 sutures at that point will not prevent migration of sleeve back into the hiatus. So over excessive dissection at the hiatus is probably the one reason why such a thing would happen. So unnecessarily putting more sutures there, initially dissecting more, then putting more sutures there, will hamper the already hampered blood supply of the OG junction. So I think the suturing doesn't help.
I think the suturing with momentum will help only when you are having a corkscrew type of sleeve, wherein you have twisting. If you feel that the sleeve is twisting, you can have a suturing which can have proper placement of the sleeve, which will not have narrowing or twisting, which can cause high pressure and proximal leave.
Okay. So NG2 post sleeve routine or selected?
I discharge patient after 6 hours, so I don't get chance to put a tube.
Check for the NG2. Digvijay?
No, I never put. Rise tube or NG tube is never in a bariatric surgeon's OR.
Okay, Dr. Chopra had mentioned
Discharging the
about-
patient after 6 hours, Dr. Navaria, can you counsel the patient about all these symptoms?
I do daycare surgeries. So they come home, to my hospital, I do, and I discharge the same day. So very rarely, only if they are insured patient, they stay for 24 hours. Otherwise, I discharge everybody after 6 hours.
When
I
you call
don't
them for
leave-
first follow-up?
I don't, after 1 week. But they remain around the hospital. They don't leave the city. So if anything required, they can always come back.
So do you
And,
counsel them for if there's any symptom like pain, fever or something?
yeah, we
tachycardia, how-
prepare them before surgery actually, that this is how the progress is. If any person who's not behaving normal the way I expect, then we can always keep them. We don't force them to go. I never tell them that you have to leave the hospital in 6 hours, but if you are comfortable, please, you can leave the hospital. And I start oral liquids after 2 hours of surgery, which is again very fast, and we keep NBM only for 4 hours before surgery. So total NBM period is only say 6 to 7 hours.
4 hours pre-op and 2 hours post-op means.
Stop.
That's wonderful.
PPI therapy post sleep. How long do you want to guys give?
Yeah, everybody gets PPI.
For how long would you give, Dr. Mandra?
At least for 2 months.
Digvijay?
So we give PPI till the patient for the initial 6 weeks, because that's the time period when the diet is frequently changing for them, and sometimes it doesn't go down well. So we continue PPIs for that period of time, and then we gradually taper it off after 6 weeks.
Okay. Anything else to Smita you want to ask? Or anybody else on the forum are open for any further questions on the tips and tricks of sleep gastrectomy?
Dr. Narwarian patient is failed sleep. Yeah, Dr. Moise has said he is doing endoscopic gastroplasty. But what is your preference? Patient with failed sleep?
And Dr. Smita,
And which patient for which which operation for which patient?
Yeah. See,
How
if
do
you
decide?
look at my experience, I was the first one in India to do laparoscopic gastric plication. And I did a randomized trial comparing two group, comparing sleeve gastrectomy with gastric plication, which was published. And I had to stop the clinical trial in between because the results were not encouraging. And we had to publish that the sleeve is superior than the gastric plication. See, the laparoscopic plication is a better controlled suturing procedure compared to endoscopic suturing. So we cannot have the same control because we can put a bougie and we suture the plicate the stomach around the bougie, and you can create a better narrowing of the stomach tube. Even that failed. So LSG, the gastric plication was having its it was famous for almost 3 to 4 years, or people were talking in every conference about gastric plication, and that I had shown first time in India in 2009 in our national conference, which when I was doing, people were surprised to see that surgery in the national conference. But though it was investigational procedure, I had shown it to the people, and then we did a clinical trial, and then I only told people that we should not do it. So since my experience of gastric plication, I never try to do endoscopic plication or endoscopic sleeve gastroplasty, because I believe that resecting a fundus is the most crucial part, which will reduce the gradient level, and we can have early satiety, and that is the most
What is
part
your procedure of choice in failed sleep gastrectomy?
Roux-en-Y gastric bypass is
To
what
all
I
patients?
prefer.
Or
Failed sleep, yes.
MGB?
See, We can do MGP also, but the problem with MGP is that we cannot decide the length of loop which we want to anastomose with the pouch. So minimum 250 centimeter is the length, and if we count the length, many people even they may come with frequency of stool and diarrheas or malabsorption symptoms. So my personal preference is banded gastric bypass if BMI is high, or Roux-en-Y gastric bypass is the preferred choice.
Thank you. Any more question, Dr. Prabhu, Dr. Betty?
Not much. I think we had a good session covering most of the aspects. So I think we can just go for conclusion remarks. So Dr. Mahendra, anything? So if you're saying any young surgeon wants to learn a sleeve, tips not to make a mess of it when they first start?
Frankly speaking, what I feel is we should not do sleeve. I stopped doing sleeves in last 10 years.
Okay.
The reason is that more than 30% will come to you with the reflux, and more than 30% will come with weight regain or inadequate weight loss. So these patients, when they move in the market, they speak bad about the procedure, and people will always take them as an example that yes, this person got bariatric surgery and he's again obese. So people will not come for surgery. So I don't do sleeve gastrectomy. Maybe in a year, I do 1 or 2 sleeve. That is only pediatric patients who are not qualified for gastric bypass.
What is the message for youngsters?
So, Dr. Sunita,
I think-
if I can just add on to this, we cannot say I still do sleeve. I used to do sleeve. I still do sleeve. But I want all the young surgeons to know is that please don't take sleeve as a very simple procedure, because you are picking up a procedure where there is no endosuturing. So you feel this is just, depending on the mechanical thing, you just fire the staples and that's all. But technically speaking, sleeve gastrectomy is quite technically demanding procedure. You need to do all the steps properly to get the best sleeve, because you make one mistake and the sleeve doesn't, the results can be really disastrous in that. So you might get away with a mistake in a gastric bypass, but in sleeve, you can't make one mistake as well. So all the newer surgeons who want to start with bariatric surgery would be starting with sleeve, but then they should know the right technique. And that is what this forum is for. That the tips and tricks about doing the right sleeve, as Dr. Chaube and Dr. Mahendra Narwari explained, that this is the right way to do the sleeve. So I think doing the sleeve in a right way is the good way to start with.
So my take on sleeve is, I said, Dr. Mohit had put a nice presentation whom we choose a sleeve and in whom we doesn't do the bypass one. So that sort of holds good for most patients. I think Dr. Mahendra may agree or disagree with it. But one more thing is, nowadays what we are seeing is patients actually know what they want. I had a patient who I want to do sleeve, and she said I wanted a bypass. So bypass, they say I want a sleeve. So
I think Prabhu, it is what we want to sell. So it's up to us. If in my clinic, everyone who comes walking, they get convinced for gastric bypass. So nobody is insisting for sleeve gastrectomy.
Yes,
the reason I asked
it's how we counsel the patient.
Yeah. The reason I said
That's
to Mahendra, so I work in Bangalore, so tier 2 cities, people, because we don't have, there are some complications of the bypass with the internal hernias and all. You have doctors referring to us, specifically requesting for a sleeve, in spite they know. So it obviously depends on the BMI scale and all. So I'm just saying, as an example of tier 2, tier 3 cities where patients and doctors themselves come with saying, look, I don't want any I can manage a GERD, but I don't want to manage an internal hernia. So example, I'm just quoting as a how our
in fact, I was coming to Bangalore to do bariatric surgery, and I did only gastric bypass those days. So
and I saw you in Narayana.
5-10.
Okay, good. So any other final tips, tricks, comments by anybody? It's open to all. Dr. Smita, Dr. Bedi, Dr. Mahendra. So I think it was a very good session. I think it's covered the basics very well. People will be much more happier looking at the content and say, okay, we can do this.
Yeah, all the topics have been covered very well. And I think now it's time for the vote of thanks.
Yeah. Thank you, Sumita and Prabhu, and thanks once again. I think we enjoyed a lot. It was a good discussion and topics were so good. I think people who has joined, they must have learned a lot. Thank you so much.
Dr. Parth, to give vote of thanks.
Good evening, everyone. This concludes the 13th academic meeting of TUGSS India. It was a delight to listen to all of you. From Dr. Pradeep's tips and tricks videos to Dr. Mahendra's leak management and Dr. Mohit Bhandari's new technology, which has enchanted us all. TUGSS and India meeting happens monthly on the second Friday. It will be on the same time. All the participants will receive a certificate on the email, and this video will be available on our YouTube channel in a few days' time. I thank you all for your precious time, and good night.
Now all have a good
Thank you.
Diwali.
Good night. Thank you, Dr. Narwaria, for sparing time, and happy Diwali.
Thank you. Happy Diwali.
Thank
to
you, Dr.
all.
Prabhu, Dr. Bedi, Dr. Parth. Really
Thank you.
enjoyed the session. Thank you.
Thank you. Take care.
Good night.